Thank you very much. Supervisor, thank you very much for your leadership. Buenos dias, good morning. How's everybody today? Let me just briefly say, with the LA Healthcare Options Task Force, which was enacted by the California Endowment and supported by the California Endowment, we had a chance to look at the entire region of LA County and begin to make some recommendations to the Board of Supervisors about the restructuring of healthcare in a true public-private partnership. And we reviewed 17 reports that had been previously written regarding the governance of the healthcare system in Los Angeles County, as well as restructuring of the delivery of services. We had a chance to also look at systems that are emerging and promising practices across the nation. We actually site visited 2 New York City Health and Hospital Corporations and the Jackson Health System in Florida. And we also reviewed existing programs here in California that in their own model have worked for the patients that they serve. Notably, we studied the system of Kaiser Permanente. We studied the system in the state of Washington, Group Health Cooperative of Puget Sound. And we also looked at emerging models for the public sector, notably Alameda Alliance and the Healthy San Francisco Initiative. All of them have exemplary models, but none have the vision that Supervisor Mark Ridley-Thomas has painted for us today. And that is to create a system of the people, by the people, for the people, really with the community engagement. And that's in particular, what we found to be an important policy imperative, as has been articulated, is the idea of integration of healthcare services. It starts with engaging the community in the development and design of those systems around a system that the community will trust and use. And secondly, creating the opportunity to access services on the medical side that are prevention-oriented primary care. Many studies have shown that if you create a primary care access point, you prevent many costs and adverse consequences to the individual patient through that care. So it's a system that has to be designed around the community, based in the community, with ample access to primary care, ample access to specialty care within that context of the community, and then looking at the hospital as the exemplary model for the illness care that certainly occurs. And the nexus between all of that is addressing the disparities that exist, not only on the healthcare side that we know all too well, but the socioeconomic disparities that keep people from being healthy and empowering themselves to be healthy. So the design here would be to look at Martin Luther King, the new hospital, as a catalyst for change. That medical campus model the supervisor presented earlier is the ideal model. It starts with access to those important prevention services on a 24/7 basis. And it doesn't have to be a physical facility. It can be a facility, a medical home without walls, including those school-based clinics, including engaging the church community, the faith community, because that's where people worship. That's where people engage in social activities that can also be healthy and healthy-oriented. Secondly, is to look at the value of the economic engine. I can tell you, I work at White Memorial Medical Center in East Los Angeles, and it's a hospital that has an annual budget of $200 million a year. And until 1994, none of that stayed in the community. But we put together a partnership with the Latin Business Association, the local communities, to say, let's give the local vendors a chance to sell their services to the hospital. So instead of sending it out of state or sometimes even out of country, keep it within the community. So the hospital then began to provide those kinds of vendor relationships to local businesses. So the hospital currently employs 2,000 employees. The physicians who work there also collectively employ about 300 employees. The physicians who are our medical staff employ about 2,000 additional people. And because we now have vendor relationships where half of that $200 million a year stays within the community, we have created another 3,000 jobs. So the economic stimulus that a hospital represents cannot be ignored and understated. And the vision that Supervisor Mark Ridley-Thomas has created is exactly that. Secondly, is the engagement of the UC system is critical. But secondly, that we also need to see and ensure the reemergence of Charles Drew University as a partner in all of this. And I'm happy to say that on Tuesday the 4th, hopefully the legal action between the university and county will be resolved so that Charles Drew University once again emerges as a key player. It is the magnet for the kind of doctor that we will need. It is the magnet for the kind of rigorous studies. I'm glad to see Dr. Norris here, who is a prolific researcher who has put Charles Drew University in the top 10% of universities across the country, including Harvard, including Stanford, in terms of the NIH research dollars because of the exemplary model that he has developed. Lastly, this is truly a public-private partnership, not just the public sector and the private nonprofit sector, but also the for-profit sector. And Charles Drew has shown that opportunity to bring for-profit positions into the mix to be real partners in the delivery of a new system that will ensure everyone has a healthy start, a fair start, a safe start, and really about morality. Thank you very much.